Warm welcome to day 2. We had an exciting program yesterday and we follow with this. We're going to hear edited cases, so thank you for organizing this great aortic program for us.
If you add angulation and extreme vector forces that will pull out things more, then you need stronger, deeper, harder. You pay a price for that, but it's the only way to go.
So it's gloves on, it's jacket off and sleeves up.
Welcome to Charing Cross 2024 here in London. My name is Dittmar Böckler. I'm co-chairman of this symposium placed in Heidelberg, Germany. And with me is Professor Eric Verhoeven from Nuremberg in Germany and Professor Hans Verhagen in Rotterdam, the Netherlands. Both are experts in the field of endovascular and vascular surgery and therapy. They involve many new therapy options. And we are here today to discuss arch disease. What is the future of aortic arch treatment? And with that, I would like to start and ask you, Eric and Hans, where do you see the future of endovascular therapy in the arch? And having said that, we all know that for decades open surgery was the standard, but now we have so many other options to treat our patients. Can you give us your statement, your ideas, and your vision about this new therapeutic options we have?
Well, I think we are boarding, of course, the most difficult part for endovascular treatment, but we are at the beginning, which means that the future is probably bright. We've made some progress over the last couple of years, both technically and with the longer-term results, but there is room for improvement, and we will certainly see many companies work on new devices to make us treat the patients better.
Hans, what is your perspective?
I kind of echo what Eric just said, and basically what you said during your introduction talk as well. I mean, this is basically a experimental treatment still, and we're facing the cardiothoracic surgeons that have refined their operations for decades. With relatively good results. I mean, it's very invasive, but it's relatively good results, and we're not there yet. Exactly what Eric said. So I think in the further future, so not the first couple of years, but probably a couple of years later, endovascular will take over. But we're not there yet. There's a couple of really big issues that we haven't solved yet, and it's going to be relatively small up till that time, I think.
So having listened to you now, what are the results we have so far? What is the evidence of endovascular therapy? Let's talk about technique, complications, results. Any insights from your daily practice?
Yes, I think technically, actually, it's not that difficult. The devices are doing well. Devices with branches are relatively forgiving. We know exactly how to do it, but we have not eliminated a substantial risk of stroke, and we obviously have to take into account the risk of subclinical strokes and also the risk of increased afterload to the heart. So these are important problems that need to be studied in the future.
Okay. Hans?
Yeah, and on top of that, I think we're just starting to learn which patients are actually very suitable for this technique and which aren't. So like Eric said, we're still facing very high stroke rates, and probably unacceptably high at the moment. But now if you see the results from, say, the last 2 years, the stroke rate's much lower. And it's not only that the technique is better, but it's also patient selection. So now we know that if you treat dissections and chronic dissections, usually the patients do much better than if you have an aneurysm in the arch with a shaggy aorta. So patient selection is really important. And we're just starting to learn which patient is suitable for this technique at the moment and which is not.
So we have so many different endovascular solutions. I'm sure you have access to all those techniques and devices. When it comes to customized versus off-the-shelf, branched versus fenestrated grafts, What is your perspective on that? What is the future? Is there one way to go, or do we need all these different devices on the market? Maybe we start with Eric again.
Well, in the arch, no doubt we can look forward to having more off-the-shelf options because the branches are relatively forgiving. And so it is a plea to the companies to provide us with grafts that are readily available because many of the pathologies deserve rather early treatment. And again, when we look back at our experience with the Cook grafts, we found out that 85% of the patients received one type of graft. So we are not far from going more towards off the shelf.
Yeah, I agree with that. Especially that branches are more forgiving than fenestrations in the arch, both from an anatomical standpoint of view when you treat it, but also if you want to off the shelf, it's more widely available than for patients. One of the issues is that we haven't figured out what the material should be of the branches because we all know that the strokes don't stop at 30 days, right? They kind of tend to keep on coming, and that may have something to do with either a suboptimal anticoagulation schedule. It may have to do something with the fabric of the branches. We haven't figured it out yet, but yeah, obviously an off-the-shelf device is easier for everyone than a custom-made device. But I'm not entirely sure if we can come up with a device that one size fits 80% or so. I haven't figured it out yet.
So listening to you, I heard that we need to learn more about patient selection, graft design, a learning curve in doing the procedure. How should this service look like? Do we need to centralize that? Do we need high volume centers? Who should do this kind of difficult and also challenging procedures for our patients?
I think this is an open door question that is fairly easy to answer. It speaks for itself that we cannot do this without involving the cardiac surgeons, which automatically means that this should be done only in centers where cardiac surgery is present and also cooperating with vascular surgery very well. I think that's imperative. And I think centralization of these procedures is a must, as Hans said before, to really select the patients well and to have a neutral and objective evaluation of the patients to see whether they will get an open repair or any type of endovascular repair. And I'm not even talking by whom.
Hence, you're working in the Netherlands. I heard that the centralization is there already beginning. Can you tell us more?
Yeah, it's a bit of a painful process. It's very different than what they did in Britain, but they want to do it in a more gentle and probably more democratic way. And we just don't know if it's going to succeed or not. But for this particular type of pathology, which will always be relatively rare, small numbers, and in a way, it's the summit at the moment of endovascular skills, right? There's so many steps, there's so many manipulations that you do there that if you start a program with this, like Eric said, you definitely need a very close cooperation with your cardiothoracic surgeons, maybe the radiologist, the cardiologist, the interventional cardiologist. So it's a fairly big team looking after a fairly small amount of patients. So the only way to go forward is to centralize this at least for the next coming years, and then we'll see how big it is and whether it's kind of diluted into the country or not. But this is key. I mean, it will never succeed if we do like 2 cases a year.
So thank you for your insight. I think to sum up, we have to learn much more about patient selection, about procedural steps, and improving the designs of our devices we have in the future in our hands for the optimal care of the patients with aortic arch disease. Centralization, interdisciplinary teams, that are the key success words we heard today from our experts, Eric Verhoeven and Hans Verhagen. Thank you so much for being here, and see you next time. Bye-bye.